Welcome back to the deep dive. Today we are rolling up our sleeves and heading straight into the operating theater, metaphorically speaking, of course.
We are.
We're tackling Chapter 54 of the legendary Baily and Love's Short Practice of Surgery, the 28th edition.
A true classic. If you're in surgery or even just thinking about it, this is, well, it's the Bible, isn't it?
It really is. It's the book that has probably propped up more weary medical students than caffeine ever has.
I wouldn't doubt that for a second.
Exactly. And our specific target today, disorders of the salivary glands.
Right.
Now, I know what you might be thinking.
Ah.
Saliva. Really? Is that going to keep me on the edge of my seat?
It sounds a bit niche, I'll grant you that.
But honestly, the more I read through this chapter, the more I realized this is a really high-stakes region of the body. You've got facial nerves that seem specifically designed to terrify junior surgeons.
Oh, they do.
You've got little frogs under the tongue, stones that form like pearls but feel like gravel. It's fascinating stuff.
It really is. And, saliva is often the unsung hero of the head and neck. We just take it for granted.
Until it's gone.
Precisely. It's absolutely essential for digestion, for protecting your teeth, for lubrication. And when the plumbing goes wrong, a patient's quality of life just plummets.
It's not just a dry mouth.
No, not at all. It's about infection, it's about pain, and sometimes it can be about a life-threatening malignancy. It's serious business.
And it's been a topic of interest for a long, long time. I found this little nugget in the intro to the chapter. The oldest reference to saliva actually comes from clay tablets.
Oh, really?
Yeah, from the Akka Library in Mesopotamia, dated all the way back to 2500 BC.
That's incredible context. So what were they writing about?
They were trying to manage excessive salivation. Apparently, they were using belladonna plants.
Wow. So they recognized the symptom even if they didn't understand the physiology or the pharmacology the way we do now. That's wild.
Isn't it? But before we get lost in ancient history, let's just clarify our mission for today. We have a lot of medical students and learners listening.
Right.
This deep dive is designed to be your ready reckoner.
Yeah.
We are going to interpret and synthesize Chapter 54 to help you visualize the anatomy, to really nail the concepts for your exams and for your clinical practice.
But, and this is a big disclaimer, this is not a replacement for reading a book.
Absolutely not.
You have to see the diagrams, you need to read the fine print. We're here to build the mental framework so that when you do read the chapter, it all just clicks into place.
Perfectly put. Think of us as the scaffolding. You still have to lay the bricks yourself.
Exactly.
So here's our roadmap. We're starting with the foundation. That's the surgical anatomy and embryology. Then we'll get into the plumbing issues, cysts and stones.
The blockages.
Right. Then we'll cover inflammation, then the heavy hitters, the tumors. And finally, we will walk through the surgery itself and, of course, the danger zones where nerves get injured.
Sounds like a plan.
Ready to dive in?
Let's do it.
All right, Section 1. The lay of the land. We have three major players here, the big three paired glands. We've got the parotid, the submandibular, and the sublingual. Let's start with the big boss, the parotid.
The parotid is the largest, no question. It's sitting right there in front of your ear. But if you want to understand its pathology, and I mean really understand why surgeons sweat when they operate on it, you have to get its embryology.
It's unique among the three.
Completely unique.
The text mentions it develops pretty early, around the 6th week of gestation.
It does. It starts as an invagination from the mouth, from the ectoderm. But here is the aha moment. This is the thing that students often miss, and Baily and Love makes a great point of it. The parotid gland encapsulates late.
Okay, let's unpack that. Why does the timing of when it gets its capsule matter? It sounds like a minor administrative detail.
It sounds minor, but it dictates almost all of the pathology. Because the parotid is, let's say, late to put its coat on. The lymphatic system, the lymph nodes and vessels, are all developing at the same time in that exact same space. So since the parotid doesn't have its capsule fully formed yet, it ends up trapping lymph nodes inside the gland tissue itself.
Ah, so the lymph nodes are actually embedded within the parotid, like raisins in a bun.
That's a perfect analogy, exactly like that. And this is totally unique to the parotid. The other glands, the submandibular and sublingual, they encapsulate early, so they basically push all the lymph nodes to the outside.
So they have a clear boundary.
A very clear boundary. But in the parotid, you have intraparotid lymph nodes, and this is clinically massive.
Oh, so?
Because the swelling you feel inside the parotid might not be a salivary tumor at all. It could be a lymphoma Or it could be a metastasis from a skin cancer on the scalp that's just sitting inside one of those trapped lymph nodes.
That is a fantastic mental hook. Because it was late to the party, it got stayed with guests it didn't invite.
Precisely. And the other guest it traps, or rather, grows around, is the facial nerve.
The big one.
The nerve grows right through it, effectively sandwiching the nerve between a superficial lobe and a deep lobe.
The dreaded parotid sandwich. We will definitely circle back to that nerve later when we get to surgery because that is the danger zone.
Without a doubt.
Okay, what about its plumbing? Where does the parotid drain?
Through Stenson's duct, it's about 5 centimeters long. It runs across the master muscle, then it punches right through the buccinator muscle.
And it opens where?
It opens into the mouth opposite the upper second molar.
Upper second molar. Got it. Okay, let's move down. The submandibular gland.
Right. This one is tucked away in the submandibular triangle right under your jaw. Its duct is called Wharton's duct.
And where does Wharton's open up?
On the floor of the mouth, on either side of that little stringy bit under your tongue, the frenulum.
Okay.
Now, here's a really key physiological difference. Unlike the parotid saliva, which is very watery and serous, the submandibular gland saliva is a mixed bag. It produces both serous and mucinous saliva, so it's much thicker.
Thicker saliva. I feel like that's foreshadowing. That's a clue for the stones section coming up, isn't it?
It definitely is. Viscosity really matters.
Okay, and finally, the smallest of the big three. The sublingual gland.
Tiny little thing. It sits right on top of the mylohyoid muscle, which is basically the muscular floor of the mouth.
And it doesn't have one big duct.
No, not usually. It's more like a sprinkler. It has a series of tiny little ducts called the ducts of Rivenus. Sometimes a few of them join up to form a larger Bartholin's duct, but often it's just multiple little openings right there on the floor of the mouth.
And we can't forget the minor glands.
No, you can't. They're the unsung infantry. There are about, 800 to 1,000 of them scattered everywhere, your lips, your palate, your cheeks, your tonsils. They have no capsule at all. They just sit in the submucosa.
Small but mighty?
They are small, but as we'll see later, they can harbor some very nasty pathology. Size isn't everything.
Okay, let's do a quick check-in for everyone listening just to make sure this is all sticking.
A good idea.
So the question is, which of the major salivary glands encapsulates late, and what is the clinical nightmare that results from that delay?
Think back to our uninvited guests metaphor.
The answer is the parotid. Because it encapsulates late, it traps lymph nodes inside the gland. This means a parotid mass could be a lymph node problem, not a salivary problem. And of course, the facial nerve runs right through it. If you got that, you're ready to move on.
Let's talk about when the plumbing fails.
Section 2, cysts and stones. I want to start with this term, ranula. It sounds like something from a creature feature or a mythological beast.
Well, it's actually Latin. Rana means frog. So a ranula is a little frog.
A little frog. Why?
It's a very old visual metaphor. When the ducts of the sublingual gland rupture, mucus spills out into the floor of the mouth. It creates this kind of translucent bluish swelling under the tongue.
Okay, I can see that.
And to the ancient surgeons, it looked just like the shiny blue belly of a frog swelling up.
That is incredibly vivid. So it's a leakage problem then, not a blockage.
That's right. It's an extravasation cyst. The saliva is in the tissue, not contained within the duct. Now, usually it stays put in the floor of the mouth, but sometimes it decides to go diving. We call that a plunging ranula.
A plunging frog. Where is it plunging to?
It herniates down through the mylohyoid muscle, that muscular floor of the mouth, and it presents as a swelling in the neck. So you have a patient who comes in with a neck lump, but the actual problem, the source, is up in the floor of the mouth.
So how do you fix a frog in the neck?
This is a really critical point for any surgeons listening. You cannot just drain it.
Why not?
If you just stick a needle in it or cut it open, it will come right back. Because the tap is still running, you have to remove the source of the leak.
Which is the gland itself.
You have to excise the sublingual gland. That's the definitive treatment.
Remove the gland, remove the problem. Got it. Okay, let's pivot to stones. Silolithiasis.
Oh.
Baily in Love throws a pretty heavy statistic at us here. 85% of salivary stones happen in one specific gland.
The submandibular gland.
Okay, why? Why is the submandibular gland the stone factory of the mouth?
It's basically the perfect storm of 3 factors. We can call it the uphill battle.
Okay.
First, gravity. Wharton's duct, the duct for the gland, actually runs uphill. The gland is low in the neck, and it has to drain upwards to the floor of the mouth. So the flow is constantly fighting gravity.
All right, that's not ideal plumbing design.
Not at all. Second, viscosity. Remember we said this gland makes thicker, mucinous saliva. It's sticky, it's sluggish.
And the third factor.
Chemistry. The saliva here is alkaline, and it's super rich in calcium and phosphate.
So you have thick, calcium-rich sludge trying to flow uphill against gravity.
Exactly. It just precipitates out and forms stones. And these aren't always tiny grains of sand. They can get quite large, like little pebbles.
And what does that feel like for the patient? What's the classic story?
It's the classic mealtime syndrome. A patient sits down to eat. Maybe they just smell lemon or something tart. The brain tells the gland, produce saliva now.
And the gland tries.
The gland tries to pump, but the duct is blocked by a stone. So the gland swells up almost instantly, causing this intense pain. We call it salivary colic. Then, maybe an hour later, the swelling slowly goes down as the saliva either trickles past the stone or gets reabsorbed.
And how are we finding these stones these days?
Historically, we use coelography, where you inject dye into the duct. That was the gold standard.
Not anymore.
Not really. Now we rely on ultrasound and CT, which are much less invasive. And for treatment, we've moved into the era of silendoscopy.
Tiny cameras.
Very tiny cameras. We can actually go right into the duct, see the stone on a screen, and pull it out with a little basket, saving the gland. It's minimally invasive, and honestly, it's very cool. It has totally changed the management.
That's a huge leap forward from just cutting the whole gland out.
It's organ preservation. It's a massive deal.
Okay, let's move on. Section 3, inflammation and infection, sialadenitis. I want to present a little scenario here. You have a 6-year-old child. Every few months, one or maybe both sides of their face swell up, usually when they're eating. It just goes away. What's going on?
This is a classic presentation of recurrent parotitis of childhood. It's not mumps, because it keeps happening over and over.
So what's the cause?
It's likely due to a slightly incompetent duct opening that allows oral bacteria to sneak back up into the gland, a retrograde infection.
And there's a specific visual on imaging for this, right? Baily and Love mentions a specific look.
Yes. If you do a sialogram, which is that contrast study, you see what's called punctate sialectasis. It looks like a snowstorm, just little dots of contrast scattered everywhere throughout the gland.
The snowstorm appearance.
Oh.
Okay, note that down. Now, what about viral causes? Everyone knows mumps.
Mumps is the big one, of course, caused by paramyxovirus, usually bilateral swelling. But we're also seeing a lot more HIV-associated salivary disease these days.
How does HIV present in the salivary glands?
It's interesting because it can really mimic autoimmune diseases. You get this diffuse bilateral enlargement of the parotids. The patient looks like they have very swollen cheeks, almost like chipmunk cheeks.
And what's happening inside the gland?
Structurally, the gland becomes filled with something called lymphoepithelial cysts.
And the key difference from something like, say, Sjogren's syndrome.
Well, in HIV-related disease, the autoantibodies, things like Rho and Lalur, are absent. But in Sjogren's, they're typically present. That's a key differentiator.
Speaking of Sjogren's syndrome, let's unpack that. This is an autoimmune condition, correct?
Correct. The body is essentially attacking its own moisture-producing glands. We look for what's called the Sicca complex, or the triad.
Wait a
Xerostomia, which is a dry mouth. Keratoconjunctivitis, Sicca, which is dry eyes. And often a connective tissue disorder like rheumatoid arthritis or lupus.
Who is the typical patient for this?
It's overwhelmingly women, usually in their 4th or 5th decade of life.
And why do we worry so much about Sjogren's beyond just the discomfort? I mean, a dry mouth is annoying, but is it dangerous?
It is dangerous because of the lymphoma risk.
Wow.
The constant bombardment of the glands by lymphocytes, this chronic inflammation, significantly increases the risk of developing non-Hodgkin's lymphoma. Some studies say it's as high as 40 times the normal risk.
40 times. Wow.
So if a patient with Sjogren's suddenly develops a new, hard-growing nodule in their parotid gland, you need to biopsy that immediately. That's a huge red flag.
A critical red flag. Okay, let's move into the section that probably stresses students out the most. Tumors. Section 4.
The lumps and bumps.
The book has this massive list of tumors, but it gives us a rule of thumb that makes life so much easier. The 80-80 rule.
I love this rule. It simplifies things beautifully.
So lay it out for us.
Rule 1. 80% of all salivary gland tumors are found in the parotid gland.
Okay, so they're most common there.
Rule 2. 80% of those parotid tumors are benign.
So if you have a lump in your parotid, the odds are very good that it's benign.
Very good. But if you have a lump in, say, a minor salivary gland on the roof of your mouth,
The odds flip.
the odds flip completely. A tumor in a minor gland is much more likely to be malignant. In the submandibular gland, it's about 50-50. But in the minor glands, you have to assume malignancy until it's proven otherwise.
That's a great framework. Okay, let's talk about the most common benign tumor of them all, the pleomorphic adenoma.
Also known as the mixed tumor. It's the most common one, period. It's slow-growing, it's painless, but it has a nasty little secret.
Which is?
It has microscopic fingers, or pseudopods. Imagine a ball of Play-Doh, but with tiny little roots sticking out into the surrounding healthy tissue.
I'm picturing it.
The big surgical mistake, the trap, is to just shell it out or enucleate it. It looks like it has a nice capsule, so an inexperienced surgeon might think they can just pop it out cleanly.
Oh, wait, you can't.
If you do that, you will cut right through those microscopic fingers, leaving tumor cells behind.
And then it comes back.
It comes back with a vengeance. We call it recurrent multinodular disease. And it is a real mess to fix because now you're operating in scar tissue right next to the facial nerve. It's a nightmare.
So the rule is simple.
You never, ever enucleate a pleomorphic adenoma. You have to take a cuff of normal, healthy salivary tissue around it.
Got it. Don't shell it out.
Yeah.
Now, the other benign one I find interesting is Warthin's tumor. This feels like it has a very specific patient profile.
It absolutely does. The classic patient profile is an older man, usually a heavy smoker.
Yeah.
And the location is almost always the tail of the parotid, the bottom part of the gland.
And when you cut into it, what do you see?
It's cystic, and it contains this fluid that looks, for all the world, like crankcase oil from a car.
Motor oil.
Brown, murky, thick fluid. It's actually a very distinct pathology. It has papillary structures and a ton of lymphocytes.
Yeah.
But for exams, smoker and tail of parotid are your key associations.
Okay, we have to talk about the bad guys. Malignant tumors. What's the most common malignancy overall?
That would be mucoepidermoid carcinoma. It's a bit of a spectrum. It can be low grade, which behaves almost like a benign tumor, or it can be high grade, which is very aggressive and spreads quickly.
But there's one that Baily and Love highlights as being particularly insidious. The adenoid cystic carcinoma.
Ah, yes. The sniper.
The sniper.
I call it that because it's slow growing, but it is relentless and deadly long term. Its superpower, if you want to call it that, is perineural invasion.
It travels along the nerves.
It loves nerves. It wraps itself around them and then skips along the nerve sheath far away from the main tumor. This makes it incredibly difficult to get clear surgical margins.
So you can't see where it's gone.
Exactly. The tumor might have traveled centimeters away from the lump you can feel all along a nerve. You might think you've got it all, but microscopic cells are already halfway to the skull base.
That is terrifying. And on histology, this is the one with the Swiss cheese appearance, right?
Yes, the cribriform pattern. Looks just like Swiss cheese under the microscope.
Before we leave tumors, is there one single clinical sign that just screams malignancy to you?
Absolutely. Facial nerve paralysis. If a patient comes into your clinic with a parotid lump and they can't close their eye properly or their mouth is drooping on that side, it is malignant until proven otherwise.
And why is that?
Because benign tumors grow slowly and they push the nerve aside. Malignant tumors invade and destroy things. They eat the nerve.
That's a pearl right there. Paralysis equals malignancy. Okay, briefly. Section 5, investigations. If a patient has a lump, what's the workup?
Ultrasound is your best first line. It's quick, it's cheap, and it tells you if the lump is solid or cystic. For more detail, MRI is fantastic for looking at soft tissue margins and especially for nerve involvement.
But you need a tissue diagnosis.
You do. And the workhorse for that is FNAC fine needle aspiration cytology.
Is it safe? I know patients always worry about spreading the tumor with a needle.
It is very safe. The risk of seeding the tract with FNAC and salivary glands is incredibly low. And to report the results, we now use a standardized system called the Milan system.
What's that?
It just categorizes the cytology findings from Category 1, which is non-diagnostic, all the way up to Category 6, which is malignant. It really helps guide the conversation about whether we just watch it or we need to operate.
Okay, we've diagnosed it. Now we have to cut it out. Section 6, surgical management and the danger zones. Let's start with the submandibular gland excision. The book makes this sound like walking through a minefield of nerves.
It really is. You are working in a tiny little triangle that is just surrounded by 3 critical nerves.
3 of them.
First, the marginal mandibular nerve, which is a branch of the facial nerve. Second, the lingual nerve. And third, the hypoglossal nerve.
Okay, let's break down the risk for each one. The marginal mandibular nerve. What happens if you injure that?
This nerve runs right along the lower border of the jaw. If you cut it, the patient loses the ability to pull down the corner of their mouth. They get a crooked smile when they try to show their teeth.
How do you protect it?
We use something called the Hayes-Martin maneuver. You find the facial vein, you tie it off low down, and then you flip the upper part of the vein upwards over the jaw. The nerve usually runs right along the fascia of that vein, so flipping the vein lifts the nerve safely out of harm's way.
That's clever. You use the vein as a handle to move the nerve. What about the lingual nerve?
The lingual nerve carries sensation, touch, and taste from the tongue. It's physically connected to the gland by the submandibular ganglion. It's like a little bow tied to a dock.
You have to cut the rope.
You have to find that ganglion and carefully clip the little nerve branches connecting it to the gland. If you just pull on the gland, you risk tearing the main nerve, damage the lingual nerve, and the patient gets a numb tongue.
And the hypoglossal nerve.
That one runs deep to the gland. It's the motor nerve. It moves the tongue. If you damage that, the tongue will deviate towards the side of the injury when the patient sticks it out. So 3 nerves, 3 totally different and devastating deficits. You have to be meticulous.
Now for the big show, parotidectomy. The mission here is simple. Remove the tumor, save the facial nerve. But finding that nerve can be tricky. Baily and Love gives us some key landmarks.
There are 3 standard landmarks that every surgeon learns to find the main trunk of the facial nerve as it exits the skull.
What's number 1?
Number 1 is the tragal pointer. The little piece of cartilage in front of your ear canal, the tragus, points like an arrow. The nerve is usually found about 1 centimeter deep and slightly inferior to this pointer.
Okay, number 2.
The digastric muscle, specifically the posterior belly of the digastric. The nerve is almost always just superior to it, just above it.
And the 3rd?
The tympanomastoid suture. That's the little bony line where the bones of the skull fuse just behind the ear canal. The nerve exits the skull right around there.
So you triangulate using those 3 things. Once you find the main trunk of the nerve, you just dissect along it.
You do. You find the main trunk, and then you painstakingly follow the branches out. We usually dissect in what's called Patey's plane. That's the surgical plane between the superficial and deep lobes where all the nerve branches run. You gently peel the gland off the nerve. It really is like peeling a grape.
But even if you do a perfect surgery, sometimes things get crossed. Let's talk about Frey's syndrome.
Gustatory sweating. This is a fascinating complication, a really weird one.
So what's happening?
Well, normally, the parotid gland receives parasympathetic nerve signals that tell it to make saliva when you eat. When you remove the gland in a parotidectomy, you cut those tiny nerve endings. They're left like live wires looking for a home.
And they find the wrong home.
They find the wrong home. Sometimes they regenerate and they accidentally hook up to the sweat glands in the overlying skin.
So the wires get crossed. The brain sends a signal saying, make saliva for this cheeseburger. But the skin hears the signal and thinks it means make sweat.
That is exactly what happens. The patient starts to sweat on their cheek every time they eat.
That's bizarre. How do we prevent that?
We try to put a barrier between the raw gland bed and the skin. We can use a slice of muscle, like a sternocleidomastoid flap, or an artificial matrix. It just physically stops the nerves from reaching the sweat glands.
Crossed wires. Biology is amazing and weird. Okay, we have covered a huge amount of ground. I want to do a quick comprehension check. Section 7.
Let's do it.
I'm going to throw a scenario at you, and let's see if our listeners can beat you to the answer.
I'm ready.
Scenario 1. You have a 65-year-old male, heavy smoker. He presents with a soft, painless lump right in the tail of his parotid gland. On aspiration, you get this brown, dirty-looking fluid. What's the diagnosis?
Okay, tail of the parotid, older male, smoker, motor oil fluid. That is a textbook Warthin's tumor.
Spot on. Okay, scenario 2. A patient has a soft swelling in their neck, but when you look inside their mouth, you see this blue, translucent swelling under their tongue.
Ah, that's the little frog that's gone for a dive. It's a plunging ranula.
And the treatment is?
Don't just drain it. You have to remove the source, which is the sublingual gland.
Perfect. Last one, a bit of anatomy recall. You are in the middle of a parotidectomy. You are looking for the facial nerve. You identify the posterior belly of the digastric muscle. Where is the nerve in relation to that muscle?
It should be just superior, just above that muscle belly. That's a key landmark.
If you nailed all 3 of those, you are in excellent shape.
And if you didn't, don't worry about it. Just rewind to the anatomy or the surgery section and listen again. Repetition is absolutely key for this stuff.
So we've gone all the way from the sandwich anatomy of the parotid through the uphill battle of submandibular stones and all the way to the microsurgery of nerve preservation.
It really highlights that these salivary glands are incredibly complex. They aren't just spit factories, they are embedded in some of the most intricate and dangerous anatomy in the entire human body.
Before we sign off, I want to leave everyone with a provocative thought. The text mentions briefly that saliva influences the oral microbiome and wound healing. We are just now entering an era of salivary diagnostics. Imagine a future where the spit test replaces the blood test for a lot of things.
Oh, it's coming. It really is. We are already looking at biomarkers in saliva for everything from oral cancer to systemic diseases like heart disease. Since saliva is essentially an ultrafiltrate of blood, it holds a lot of secrets. Baily and Love just touches on the microbiome, but I think in the 29th or 30th edition, we're going to see a whole chapter on using saliva to predict systemic disease long before any symptoms appear.
Spit, the window to the soul, or at least to the immune system. That brings us to the end of this deep dive into Chapter 54. As always, our mission here was to give you the framework. Now your mission is to go open the book, look at the diagrams of the lazy S incision and the nerve relationships, and use this audio to make it all stick.
Absolutely. Good luck with your studies, and please watch out for those nerves.
Thanks for listening. We'll catch you on the next deep dive.